Okay, so good evening, everyone. Welcome everyone here from all over the world. And this is an initiative by Yemeni Neurosurgical Society. And I thank Professor Ahmed Saleh Al-Jaradi for having me here and the Neurosurgical Society of Women. It is so good to see his initiative on the webinars and internationally across the board to bring in a lot of uh, expert speakers and experienced ones to give talks on very simple topics which we clinicians on day-to-day basis we use it, but then we do not go into detailed analysis. And here we have a person, an expert who had been an honorary president of the Middle East Spine Society, the past president of World Spine Column Society and Turkish Neurosurgical Society, as well as Asia Pacific Spine Society, to just name a few. Professor Dr. Mehmet Zileli, who had been an expert trainer, a trainer of the trainers, I should admit, and his work all over the world is appreciated for its very decisiveness and in key insight into major and very complex diseases. And his art of explaining things makes looks even the complex topic go very simple. And he is touching on a very important topic, that is the anatomy of the spinal canal, meninges, and nerve roots. And to moderate the session, we have Professor Dr. Atik Ahmed Khan, who is the chairperson and the head of department of neurosurgery, Dow University of Health Sciences Civil Hospital and SMBBI Trauma Center, Karachi. So without any further ado, I would like to invite Professor Dr. Mehmet Zalili with his talk. Sir, can you please share your screen?
Thank you. It's my great honor to be with you for this great initiative. What I will try to explain here is the spinal cord anatomy and vasculature, and this will be my presentation order. First, starting with the spinal cord anatomy, gross anatomy, gray matter, white matter, spinal tracts, ganglion, spinal roots, and the spinal cord vascular anatomy. If you look at that diagram, that spinal cord occupies 2/3 of the spinal canal, only cervical and thoracic spine and the upper part of the lumbar spine. There are two enlargements, so-called intumescentia. These are the areas of the most precious nerve roots originates, the cervical intumescentia and the lumbosacral intumescentia. The spinal cord has a cylindrical shape with AP diameter flattened. It's like this, and here is the spinal ganglion, and spinal cord is shorter than vertebral column, and we can understand the levels of the spinal cord by looking at the anatomy like this, as if four limbs animal. And spinal cord elongation stops at the age of 3 to 4. In the newborns, it is till L3-4, and then it shrinks a bit by lengthening of the spine to the level of L2 body. And the segments are cervical 8, thoracic 12, lumbar 5, sacral 5. And one important point is that on the body, it is from C4 level to suddenly passes to T3 or T4, but the C5, 6, 7, 8, even T1 are represented in the arm. So then you will hear from your residents that in a quadriplegic patient, the level of the sensory deficit is T2, 3, T4, they will tell. which is not the correct level. The conus medullaris is because of tapered conical structure of the ending at L1, L2. This is because it is conic shaped, and it includes all the sacral levels. And the filum terminale is a extension of pia mater extending inferiorly and anchors cord to the coccyx. And the cauda equina is an anatomical description that all the cauda, all the nerve roots here collected, and it looks like a horse's tail. Nerves arising from lumbar sacral and coccygeal portions are making the cauda equina. If you look at the spinal cord, there are longitudinal divisions like median fissure, which includes anterior spinal artery, anterolateral sulcus, which the ventral roots enter the spinal cord. In the posterior part, posterior median sulcus, and two posterolateral sulcus, which includes again attachment of the dorsal roots. Dorsal roots enter from the posterolateral sulcus inside the spinal cord, and there are two small posterior spinal arteries here. What about the gray matter? This is the gray matter, as you know, and there are so-called anterior horn and posterior horns, and intermediolateral horn here on the lateral part, especially in the thoracic spine. This is the intermediolateral horn, and there are laminas of gray matter. In fact, these laminas are described for the cat's spinal cord, but it is also used in the human spinal cord. There are 10 such gray matter laminas, and one of them is the Lissauer's tract in the most dorsal part of the posterior horn, which represents pain, temperature, and light touch fibers. Then on the posterior part, there are 6 laminas. They are sensory laminas. And lamina 2 is the substantia gelatinosa, which is the important part in pain mediation and substance P. What about anterior horn laminas? There are so-called Clark's column in the dorsal nucleus, intermediolateral nucleus, and there are motor neurons inside the anterior horn. These are the second motor neurons. Where are the first motor neurons? There are on the brain cortex, in the pyramidal cortex, so-called premotor cortex. So what are the importance of the gray matter? One of them is the substantia gelatinosa, second layer, as I mentioned before. To make a lesion on that region is so-called dorsal root antizone lesion, dress surgery. This is done for central pain, mostly deafferentation pain. And there are 2 different techniques to do that. One is the Nashville's radiofrequency lesions, 2-3 millimeter apart, multiple lesions on the dorsal part with a specially designed lesion electrode. The other one is the Sindhu technique, first making a incision on the dorsal root entry zone, and then small bipolar coagulations. This is the Sindhu technique. So Neuroanatomy or dorsal root entry zone surgery is for the pain used for brachial plexus avulsion or deafferentation pain, post-herpetic pain, and some amputational pain. What about the anterior horn cells? What is the significance of that clinically? This is the second motor neuron, as you know, and the so-called motor neuron disease, ALS, is the lesion on those motor neurons, and it is not a surgical disease, as you know. And this is the typical appearance of the ALS patients with atrophy and some deformity in hands. This disease is together with the fasciculations in upper limbs mostly. There are also pyramidal tract findings and no sensory deficit. One of the most important findings is that they have no sensory deficit. We can also see similar atrophy in some cervical spondylotic myelopathy patients because of compression of the spinal cord and more affection of anterior horn cells can happen, and some atrophy in hands may happen. If there is significant atrophy, the prognosis of that the compressive surgeries are not very good. What about the white matters of the spinal cord? There are dorsal, lateral, and ventral white matters. And if you look at the dorsal white matter, there are so-called fasciculus gracilis and fasciculus cuneatus. Fasciculus cuneatus is the representing the deep sensory and touch sensation of the upper limbs. However, fasciculus gracilis in the midline more medial part represents the lower limb deep sensation. Lateral corticospinal tractus is here. This is, as you know, the tracts coming from the premotor cortex down to the second motor neuron. And spinothalamic tract is the pain and temperature sensation representing, and it's a very wide region they are placed. And there is also some other tracts which are not clinically significant, although they have been defined by the tract staining methods, but clinical significance is not well known, like rubrospinal tract, descending autonomic tracts, vestibulospinal tracts, and tectospinal tracts, and others. As you know, there are two corticospinal tracts. One of them is the lateral, the other one is the anterior corticospinal tract. And if they are affected, the voluntary movement in the ipsilateral part, mostly for the lateral corticospinal tract, is affected, but anterior corticospinal tract is not is not crossed to the other side. It's from contralateral. This is the representation of the corticospinal tract. The decussation is in the lower medulla oblongata. So, clinical significance is the first motor neuron type of paresis. Actually, somebody can not understand what is the reason if there is a spinal cord compression. There is a first motor neuron type paresis, because mostly by such a compression is the corticospinal tract is affected. Occasionally, not very often, can also be anterior horn cells affected, and atrophic part of paresis may happen. But it is on a segmental level, not in whole lower level muscles affected. Lower level muscles are spastic, but in a segmental level, it may be atrophic pattern, second motor neuron type of paresis. As I mentioned before, fasciculus gracilis and cuneatus is ascending tract of position sense, and spinothalamic tract is pain and temperature sensation. And dorsal column or fasciculus gracilis and cuneatus are ipsilateral. However, anterolateral spinal tract is contralateral. Here is dorsal column system, and here is the position and vibration and light touch disturbance by affection of the dorsal column. This is clinical significance is there, and spinothalamic tract, after entering from the spinal ganglion and dorsal roots, they then decussate 2 or 3 level up to the level. So because of that, there are in case of a compression from one side to the spinal cord, so-called Brown-Sequard syndrome may happen, which with ipsilateral paresis and contralateral sensory and pain sensation loss. One important thing is the CT-guided cordotomy, which can be done in cases of unilateral pain syndromes. Some malignant tumors may have ipsilateral pain, especially visceral organ, some chest carcinomas, lung carcinomas may have significant pain. In those cases, a CT-guided cordotomy may be very helpful. It is with entering at C1, C2 level, entering the spinal cord from one side and giving some contrast medium inside, and then making a small lesion like this by radiofrequency lesion. This was described by Professor Yücel Kampolat from Ankara, Turkey. In general looking, posterior columns are for deep sensation, position, and vibration sense. Corticospinal tract is for motor representation of the pyramidal tract. Spinothalamic tract is for pain and temperature sensation. And after learning these anatomy, spinal cord lesions, which was described by Brackman and Penning, is central cord syndrome, anterior cord syndrome, and Brown-Séquard syndrome can easily be understood. Central cord syndrome is the more paresis on the upper extremities. The reason for that is that the medial part of the pyramidal tracts are affected more than lateral parts. So this is the central cord syndrome. Another reason of affection of upper extremities can also be anterior gray substances affection. Not just pyramidal tract, but also gray substance affection. Central cord syndrome happens mostly in hyperextension injuries of a previously narrow spinal canal, which can happen especially in the elderly people by hyperextension of the head, as I mentioned, because on flexion, normally there is a physiologic widening of the spinal canal. However, in extension, it narrows. There is a physiologic narrowing of the canal. If there is already some degenerative narrowing, a hyperextension injury will cause a diffuse edema or some hemorrhage inside the spinal cord. This happens mostly in more fragile area of the spinal cord, which is the middle of the spinal cord. They are more fragile. Anterior spinal artery syndrome or anterior cord syndrome is another clinical significance. It happens after some vascular lesions of the anterior spinal artery, and also some injuries may cause this, which then there is a sensory preservation of the position sense preservation. However, significant paresis, even pinprick and temperature sensation loss. Brown-Séquard syndrome, as I mentioned before, is a hemisection. Mostly happens with the step wound injuries or some penetrating injuries. And this is ipsilateral motor and position sense loss. However, contralateral pain sense loss. Posterior cord syndrome is very uncommon. I've seen a few cases only. There is a loss of below the level of position sense and fine touch and some ataxia. Sacral sparing is another issue that we must learn from that anatomy. Caudal segments are represented on the outer parts of the spinal cord. And if there is a sacral sparing, because the outer parts are less injured with a blunt trauma, and if there is a sacral sparing, this type of lesion is not a total cord lesion. So if you see significant recovery after a total cord lesion, I will claim that the first examiner did not look at the sacral sparing, because examining perianal area with a pinprick is not properly done mostly, especially in emergency care patients. So then we then mistakenly think that this is a total cord lesion. So spinal cord monitoring is another issue that we monitored during surgeries of which we can cause neurologic compromise. There are mainly two types of monitoring. There are also some others, but I will mention two of them. One is somatosensory evoked potential, which is however, motor evoked potential is a function of the pyramidal tract. Somatosensory evoked potentials are elicited by median nerve or tibial nerve stimulation from the sensory cortex by averaging the potentials. At least 100 or 200 stimuli are given, and then you average them. So then it takes 3 to 5 minutes to get a potential, if there is or not. However, motor evoked potentials by stimulation of the motor cortex during surgery you can make with electrical stimulation, and you must have no muscle relaxation with this, and get the potentials from the muscles itself. So we call it myogenic potentials. There is another one, so-called D waves. You stimulate again the motor cortex in the brain by electric stimulation, but you pick up the potentials from epidural, then so-called D wave. They are more robust because they are not going with multiple synapses, only one synapse. So D wave is a better recognition of the spinal cord motor tracts. There are so-called spinal cord potentials as well. You can stimulate the upper spinal cord level and get the potentials from the lower spinal cord level. So if there is a lesion somewhere in between, you can understand if there is a block of the potentials by such a recording. These are myogenic motor evoked potentials and D wave potentials during surgery. There is a central canal as well in the middle of the spinal cord. This is a representative of the ventricles in the brain. This is filled with CSF, and superend is contiguous with fourth ventricle. And if there is an enlargement of that canal, we call it hydromelia or syringomelia. There are multiple reasons of hydromelia and syringomelia. There are posterior dorsal roots or anterior ventral roots, which then form, they conjugate, and which then form first a plexus, then they make another divisioning, and they form the peripheral nerves. And here there is a dorsal root ganglion, which is a very robust structure at the back. This ganglion is very important for spine surgeons, and it includes pseudo-unipolar cells, which forms the monosynaptic reflex of a part of the monosynaptic reflex. In case there is a harmful irritation of one of the nerves, then it doesn't go to our conscious level with the sensory tracts, descending, ascending tracts. It then makes a reflex connection here, and then you can draw your hand or leg from a harmful stimulus. Spinal ganglion is clinical significance is too much because it is a source of neuropathic pain. Parietal disc herniations squeezes the spinal ganglion, and they must go to surgery earlier than the other disc herniations. And transforaminal endoscopy can make some damage to the ganglion, and we must be very careful for that. And dorsal root ganglion stimulation is another technique to diminish the pain of some patients. So-called Cambian's triangle is described to enter the disc space with safety. This is the Cambian's triangle. And in that triangle, the spinal ganglion can be injured, and we must be very careful if we are trying to make a transforaminal endoscopic surgery. I will not give you much. I don't have much time to talk more about the dura mater, the very thick membrane, and CSF dura rupture and CSF fistula are a big issue of our surgeries. It's a kind of complication, and just underneath is the spider-like arachnoid membrane. There is a subdural space between dura and arachnoid, and subarachnoid space between arachnoid and pia mater. And then the conjugations of pia maters also make dentate ligaments. In the past, we used to do that dentate ligament incisions to make some decompression of the spinal cord, which then we left it because it doesn't make much sense to release the spinal cord by cutting dentate ligaments. Spinal tap or lumbar puncture is a kind of investigation which especially neurologists want to see the CSF structure and biochemistry to make some diagnosis of some neurologic diseases. Arterial supply of the spinal cord is very delicate, and it's mostly by anterior spinal arteries and two small posterior spinal arteries. And there is one so-called Adamkiewicz artery coming from the thoracolumbar level by this shape, and it is, however, not affected by many complex spine surgeries, but more often it may be endangered by aorta replacement surgeries done by vascular surgeons, because they are dividing, they are cutting or replacing a large part of the aorta, and then many segmental arteries are ligated, which then include Adamkiewicz artery, and then it may cause spinal cord ischemia and paraplegia. Pre-op identification may be necessary if total spondylectomy is planned or aorta replacement surgery is planned. Thank you for listening to me. This is my talk. I want to introduce you to Istanbul Spine Masters we will make in this April, and Kazakh Spine Days in Astana 16 to 17 May, and APCSS meeting in Istanbul November 7 to 8, and this is the course in November 2022 in Izmir, Turkey. Thank you for listening to me.
Thank you, Professor Mehmet,
Thank you.
for a wonderful talk. In fact, you started with a representation of the human spinal cord representation, dermatomal and neuromal, as comparing to the quadruped animals. That's how we can actually understand the lumbosacral outflow much more easier. Then you talked about the DRE zone and the DRE zetomy and the Sindor procedure by talking about Lissau's and the lamina 1 to 6. And then you talked about a very important mimicker of spinal cord injury in terms of anterior horn nucleus involvement in ALS, where one has to be aware of it. Otherwise, we can confuse it with the compressive syndromes. And then you talked about the white matter pathways, comparing the lateral outflow and the anterior corticospinal outflows, and the procedure of cordotomy, which in fact has a very selective indications, as you rightly said, for malignant conditions at the level of C1 and C2 to control intractable pain. Then you had a very good talk on complete versus incomplete cord syndromes on the various aspects of its presentation. Then a very important aspect of spinal cord monitoring, both somatosensory, SSCP and MEP, and also the talk on D wave and how it is relevant. And then you touched upon dorsal root ganglions importance in terms of neuropathic pain it can generate, transforaminal endoscopy, its relation to it, and nowadays DRG stimulation, which is being done by our interventionist. Denticulate ligaments are definitely very important, particularly when we are talking about the third cord syndromes, or when we are mobilizing the cord to attack on the ventral aspect. And then you also talk about the arterial supply of the vessels, which is also very important for us to understand when we are looking at different vascular structure pathologies, maybe an AVM or a dural-based pathologies. So that was very wonderful talk. And before we open the discussion further, may I have the opinion of our moderator, Professor Atiq Ahmed Khan, to have his words on the talk and any important clarification one would ask for.
Thank you, Amit. I think I must say without any compulsion that this is really a commendable effort from Professor Mehmet Zalili to encompass each and every aspect with a clinical touch. You see, he's not only describing the anatomy, but he's uh, telling us what the neurosurgeon should not do. And this is a dangerous zone. They should be taking care of gray, white matters, and specifically the arterial supply. So, really, encompasses it so quickly that, and he covered each and everything, and he omitted about the dura, and he did it very rightly because it will become more lengthy. And a very famous psychologist, Sigmund Freud, says a person cannot grasp more than 17 and a half minutes. So I think I'll give full marks, and I'm really happy that this is the way how a professor of professors describe the anatomy of the spine. It's learning for me as well. I think the candidates who are listening, they definitely get some of the important lessons from that, like specifically talking about the, because nowadays we had a Olive workshop in our university by the pioneer of Olive, that is a oblique lumbar interbody fusion, and he described about the Campine's triangle, and we had him here. He came all the way from America, and this WFNS when going on in Dubai. So we are having a workshop with Amanda and the other guy's name is Hassan. So, so he also described that Camby's triangle. So, and he also described that how it is important that during endoscopy you can have an injury to that. So the OLIF is a new introduction and to the spine surgery, and so I am really, impressed with Professor Mehmet Zalili, and I think that I will open this forum for discussion.
Thank you, Professor Atik. And in fact, we have one query, and this was, I also was thinking to put this up to Professor Mehmet regarding the evaluation of neurogenic shock versus spinal shock after the injuries of the patient of the spine. And we have one query on the floor by Dr. Ahmed Al-Ghanemi. He is asking if the return of the bulbocavernous reflex signals the end of the spinal shock. Why does the transition to autonomic dysreflexia often takes weeks to manifest?
Yeah, good question. Thank you. If we are talking about the term spinal shock, there are confusion. There are two types of terminology. One is the spinal shock is sorry. Sure. One is the spinal shock that the significant decrease of blood pressure after a mostly cervical spinal cord injury or upper thoracic spinal cord injury. It happens because a sudden loss of sympathetic activity and then a vagal activity dominance causes that blood pressure drop. And additionally, there is also some bradycardia. So we must fight against this in spinal cord injured patients, and many physicians call it a spinal shock. Another term is to describe that there is, after a significant compression of the spinal cord or a contusion of the spinal cord, there is a loss of deep tendon reflexes. It is like there is a flask paraparesis or quadriparesis. It is then as if the spinal cord has lost his commander coming from the brain and is silent for a period, mostly 2 to 4 weeks long. After that period, the reflexes come back with some spasticity. It is same for autonomic dysreflexia. Autonomic dysreflexia is a kind of sympathetic over reaction of the body by getting a standing position. It is again a similar thing. But there are two descriptions. One is for blood pressure depression, hypotension, is a spinal shock, we can call it. The other one is the loss of all reflexes and flask paraparesis, paraplegia, because of the spinal cord cannot react itself for a while. It is 2 to 4 weeks. But it doesn't mean somebody can mean that period is not a period of the spinal cord will then heal after a while. If the lesion is very severe, it will then turn only to spasticity. It doesn't mean that the transmission of the lesion level will test after spinal shock.
True. Apart from that, you have actually mentioned a lot of procedures during the talk. But then what we have seen during our practice these days are that a very good procedure called selective dorsal rhizotomy has actually gone into fade, which in the past had been used very frequently for cerebral palsy, spastic variety. And we have a very definite age group of the patients who responds to this SDR. So, Professor, do you like to highlight on this procedure? Because this is something which we like to our neurosurgeons to know, because somehow during the evolution of neurosurgery, we have lost very good procedures which
Yeah.
could have been offered to the patients, but then because we are not exposed to it, it is not being routinely done. So, please highlight on selective dorsal rhizotomy and its
Yeah.
role in its cerebral palsy.
Especially in severe spastic patients, there is still role of it, but it must be done together with a good collaboration of a neurophysiologist, because during the surgery, the surgeon must identify all the dorsal roots, and only the ones who give early responses to stimulation must be cut. So because of that, it is called selective dorsal rhizotomy. Not all the dorsal roots should be cut. If you cut all of them, then you will have a very flat patient, which will not be good to stand erect, to stand up. But in good hands of surgeon and neurophysiologist, you can get very good results after selective dorsal rhizotomy.
True.
This
So
is
that's
for
why,
spasticity only.
yes, yes, and that's why sometime some of the institutions also do baclofen injections, testing whether they respond, because that's one of the reversible way for spasticity, and then they go ahead with this procedure because this is somehow a permanent procedure. And as you said, we always like to monitor from L2 to S2 myotome and see by stimulation the dorsal nerve root. So we cut only those nerve roots which gives at least 50 to 70% stimulation. So that's a very
Correct.
good thought. Yeah.
Yes, very correct.
Yeah. So that's
Thank you.
great. And can you also highlight on how the aging in elderly population can affect the anatomy from the neurosurgical perspective? What should we aware of when we are looking at senior citizens coming with a spinal cord problem as compared to the younger age groups? What do you think as a clinician should be wary of?
Yeah, good question. Actually, we are having too much spine problems, the bony and motion segments problem, but not spinal cord problems in the elderly. It's not that much. Uh, uh, we can expect more vascular spinal cord problems in the elderly, but fortunately, we don't see too much. So if you are talking about spinal cord, there is not much problem in the elderly is in comparison to spine problems. I mean, the bone, there is osteoporosis, there is a disc degeneration, there is a so-called uh, adult deformities, mostly in adult ages, the patients, the normal population tends to get kyphotic, such problems. We can talk it in another session, probably. This is very common. So because of that, the currently spine surgery becomes more and more a geriatric surgery.
Okay, all right.
Yeah,
But
that's true.
just wanted to I wanted to ask one thing that during the presentation you described that about the hyperflexion and hyperextension injuries. That is a trivial amount of trauma in an elderly patient, specifically talking about the spine. where
Right.
the patients may have osteophytes and the
Right.
diameter of the canal is compromised, already compromised. So it's a,
Right.
a trivial amount of trauma, a slight whiplash or an inflection or extension injury, specifically the hyperflexion injury as you're talking about, that will lead to cord contusions. And that's what we see in here in Pakistan. And people are very unaware of that. And because they don't have, previously, they don't have any neurological symptoms, but they have a very compromised canal. And suddenly
Right.
it comes up with trivial amount of trauma that lead to severe quadriplesis,
Right.
and that is the problem, because we cannot screen every elderly patient, for that. But
Right.
but that's what is. I think that's what Amit is asking, I guess.
Yeah, no,
Yeah.
right. And in fact, Professor Mehmet did answer this question, because if we do an MRI in any patient above 60, 65 years plus, we will definitely have a lot of degeneration seen on an MRI. So as a
Uh,
clinicians, we should not jump on any intervention immediately. We have seen a severely kyphotic individual doing his or her activities in a very much good manner. So they do not present with lot of neurological, so-called neurological deficits, even though they may be degenerative spinal column disease, but then they will not have too much of neurological disorders. So these patients can be safely, conservatively watched rather than offered a direct surgical treatment. So we should not treat, in fact, we should not treat MRI images in these patients, and try to offer the treatment on clinical basis. So that's a very good thought on it. And may I ask Dr. Ahmed also to have any queries or any comment?
Yeah. You know, uh, according to the recent statistics, the spinal trauma is increasing in the developed countries in the elderly only, because of the falls from heights. I mean, they just fall when they walk. Uh, and these falls can cause, as I mentioned before, in case of cervical hyperextension, significant quadriparesis. This was described in 1920s by Schneider. He was telling that it is a hyperextension injury, and the result is a central cord syndrome. However, in the low and middle income countries, the incidence is increasing because of they are having too much motorcycles, they are having too much the cars, and without any good infrastructure, and they are having too much traffic accidents. And so then there is a slight change of epidemiology of the spinal trauma. We must be more aware of elderly spine trauma and try to avoid it by different measures. Thank you for making this comment.
Yeah, another aspect which we are looking these days is the increasing incidence of osteoporosis amongst the patients, particularly
Exactly.
again, early age group, and even in the middle age group. And to my surprise, even in countries like Nepal, where we have very good sunshine throughout the year, and people are exposed to a lot of outdoor activities, maybe
Right.
because some reasons we do not know, but vitamin D deficiencies are fairly common. And so these two like deficiencies, they are actually causing much more of spinal column disorders. So what
Right.
are your thoughts on it, and particularly in relation to managing patients with instrumentations? So role of vitamin D deficiencies and increasing incidence of osteoporosis while offering a patients an instrumentation. So how do you go about it, Professor Menon?
Yeah, this is a fact. Actually, this osteoporosis is more common if you don't get good sunshine exposure. And so if you are not getting a good nutrition, especially protein, less proteins and less milk substances, they are increasing. So osteoporosis is a big concern for the spine surgery in the elderly. All the medical practitioners must be aware of this, especially the vitamin D deficiency and less calcium intake, worse nutrition of the modern life people. This is very common.
That's true. That's true.
I
Yeah,
think
over
Ahmed,
yeah.
I think Ahmed need to say something.
Yes.
Thank you very
Ahmed
much.
Saleh.
Regarding, I have maybe a small comment regarding the talk that in elderly patients, we usually in MRI, we see some stenosis and degenerative spine, and we can safely follow up conservatively without any consequences later. I think this is a baby in all the ages. The spine, also that it has some degenerative spine and has osteophyte, but it is rigid, more rigid, and there is less motion in the spine itself. So there is less chance to cause compression on the spinal cord. So in this elderly patient, when we have an MRI and we see there is a osteophyte and there is canal narrowing, as Dr. Amit said and Professor Muhammad said also, we don't jump to surgery if the patient is asymptomatic, because the mobility in the spine is less and the chance of injury is less. It's only the risk in this patient is trauma. Even minor trauma can cause fracture because of the more rigidity of the spine associated also with osteoporosis, which make the spine more susceptible to injuries and fractures.
True.
Yeah, obviously. I think as we were discussing about the elderly patient with trivial amount of trauma, with already a compromised canal, and they came up with a cord contusion and quadriparesis and quadriplegic. Initially, I think Amit is completely right. I will definitely give 100% marks to Amit by initially a conservative management should be a good approach rather than as I've seen younger generation, they are trying to fix this spine, they are trying to fiddle around with the cord. Already a contused cord will definitely injured more with the surgical intervention. So if you see any cord contusion, I think unless and until it is an unstable spine, one should refrain himself from operating early rather than later on. Let's everything boils down first. I think let's the contusion to resolve, and then see the neurology and can decide later on. I think that's a good approach.
Yep.
I think we should finish because it's. I think we have discussed, or somebody wanted to ask some question. Then he's most welcome.
Dr. Atabati wanted to ask something, I think.
Professor Zileli, it's always learning experience to participate in your lectures and to see you. Every time we learn new things. You mentioned regarding the vascular aortic uh, supply and vulnerabilities. So my question is, in which procedures would you anticipate that the vascularity vulnerability is there? One thing. And if you are interested to explore the vascularity, then what investigation modality you would prefer?
Yeah. it's not common to get a vascular compromise in many spine surgeries, because although there is a so-called Adamkiewicz artery, we don't see any problem even if we compromise that artery itself. If we are letting the others there, I mean, this is questioned. But if you are making a total spondylectomy at these levels, especially in the thoracolumbar junction, I would then ask to get a angiography of the to see which level Adamkiewicz enters, and probably aorta replacement surgery. The thoracic surgeons, or sorry, vascular surgeons, can also ask the artery. Can they want to know where does it enter? Otherwise, I don't care much in other surgeries.
Yeah, that's true. And in fact, we also like to add, if in case we have some suspicions of vascular malformations, then we need to have a very, very comprehensive evaluation at each intercostal and lumbar levels if we are talking of a dorsolumbar EVM, dural EVM.
This is correct. Yes. In case of spinal cord vascular malformations, yes. But I mean, for spine surgery, total spondylectomy is a big surgery, and it's not done very often, fortunately.
That's true.
Thank you.
So I don't see any further questions, anybody raising hand, and let me summarize this session to be a very fruitful one. Very, very thankful to Professor Mehmet Zileli for giving us a time and wonderful talk, very comprehensive in a very neat and concise manner. A sort of a learning experience from all of us here in this webinar. And also like to thank Dr. Atik Ahmed Khan for giving us a very good moderation and giving us guidance to this whole session. And of course, words of appreciation to our dear friend Ahmed Saleh Al-Zarati for organizing a wonderful webinar. And thank you, everyone. And we may have a final word from our moderator as well as the organizers, please.
Okay. I think this is an excellent session for not for the residents but for us as well, as exchange of thoughts and exchange of ideas, and and specifically as we seniors discuss and try to learn from the giant of the spine surgery, Professor Mehmet Zileli. It was really a wonderful experience for all of us, I guess. And we have raised our questions as we face the difficulties. So, and he really gave a spot on answers. So from my take, I think this sort of discussion should always continue. It's always fruitful. It's always helpful. And I think that the academic WrestleMania should goes on. Yes, thank you.
Thank you very much, Professor Mohammed Zileli, for this wonderful presentation and beautiful talk. And also thanks to Professor Amit Thaba and Professor Atik Ahmed Khan for this excellent webinar and excellent presentation. And we have very excellent webinar today. And as Dr. Atik said, we all learned today and we all enjoyed this session. So thank you all very much.
I thank you all. It was great night to discuss with you all these aspects. Thanks a lot for invitation.
Thank you.
Goodbye.
So thank you, everyone, and see you all, inshallah, next week with more
Goodbye.
presentation and more webinars. Thanks, everyone.